Hi, my name is Steve August. I'm a New Zealand physiotherapist. I have a special interest in costochondritis because I had it for 7 years myself in my 20s, fixed it, and haven't had any pain whatsoever for 30 years. There's nothing like having the problem yourself to actually give you a feel for the patients who have it. This is a look at the available research on costochondritis and on Tietzes Syndrome. There is not all that much of it, and this is an informal overview of what I've found going through it and what you would find if you go back to the original research papers. Not many people do this. Now, the popular view of costochondritis is that it's a mysterious inflammation, nobody really understands what's going on. You see this on all the popular medical sites like WebMD, Healthline, the Mayo Clinic. Says costochondritis has no apparent cause. The exact cause of costochondritis is unknown. eMedicine Health says costochondritis is an inflammatory process. Nevertheless, it has no definite cause. The overview, jumping ahead to the conclusion, is that we think this is a red herring and that costochondritis, regarded as a mysterious inflammation, is not a good model for treating it, and that's why most of the treatments don't work. The New Zealand view is quite different and is actually supported in the research in a way that the inflammatory, mysterious inflammation idea is not, and we've been through to the research and had a look. The New Zealand view is that costochondritis, almost all of it, happens because the rib hinges around the back, costovertebral joints, costotransverse joints, where the ribs are hinging onto the thoracic spine, are frozen. Immobile or hypomobile, can't move. When that happens, the rib hinges on the breastbone, the costosternal hinges, have to move excessively just to let you continue to breathe and move around. So that means every breath you take, unlike every other hinge in the body which gets a rest, the costosternal ones are being strained and overused every breath you take and whenever you move, if the hinges around the back can't move. The best way of looking at the rib cage is think of it like a bucket handle. If you move the bucket handle around, the hinges move on the front and the back. Okay, if the ones around the back can't move, then the ones on the front have to move excessively. So that's the overview. So let's have a look at the actual published medical research in peer-reviewed articles and in medical letters and see what's there, because it's fairly odd. 1921, Dr. Tietze, German doctor, described 4 patients only with what has become known as Tietzes Syndrome, which is pain where the ribs hinge onto the breastbone, lots of swelling. Now, Tietze himself said it's not an inflammatory swelling. It's there in the original paper, but nobody seems to go back to that. So he himself is saying it's not actually an inflammation. Biopsies are not showing inflammatory material or anything else particularly dire. The word costochondritis comes in around about the 1960s in common usage. Now before that, it used to be called costochondritis, chest wall pain, costosternal pain, sternocostal pain, costal chondritis, all these different words. And then around about the 1960s, this word costochondritis started getting used. Now, the itis ending means an inflammation. So it seemed to have an answer to busy, harried doctors that this was actually what was causing this mysterious chest pain, and that, great, we know what to do about an inflammation problem. We hit it with anti-inflammatories and maybe steroid shots and all. Now, in terms of the research, no one has ever, in April 2019 when I'm recording this, no one has ever done a clinical trial to test whether anti-inflammatories or steroid shots into the joints actually help with costochondritis. Now, there are things out there that are still valid but which have never been tested. For instance, nobody until very recently had done a randomized controlled trial on whether a parachute works if you jump out of a plane. It's a bit difficult to get placebo patients prepared to do that. So there are things that exist which are not covered by randomized controlled trials. Nobody has ever done a randomized controlled trial on any aspect of costochondritis. When you actually go to look at the available research, there's not all that much of it. It's definitely less than several hundred mentions. It's really only a few hundred individual papers, and frankly, most of them miss the point. So, the sort of research that started coming through from, and mention of costochondritis from the 1960s just starts to use this word costochondritis, and to busy doctors, this seemed like an answer to what was going on. Now, this is actually human. I've asked various doctor friends of mine about this, and it's always the same story. Someone comes in with acute chest pain, help, it could be heart. So they're poised to do the very highly skilled, concerned, life-saving techniques, and the tests start coming back negative. And so gradually, when we decide it's not heart or lungs or cancer or anything else dire, we can relax, tell the patient that it's just costochondritis, it'll settle down, take these anti-inflammatories if it needs it, next patient, please. This is completely human and quite reasonable, but it's actually not accurate. The size of the problem is quite large. Every year, there are about 6 million emergency room emergency room visits in America, and about 1 million A&E, accident and emergency visits to hospitals in the UK. Now, there are varying estimates of how many of these are costochondritis. Certainly, most of them are not heart, so at least up to 60% are, inverted commas, atypical chest pain, which basically means not heart or anything obvious that anybody can pick out. So most of these are probably costochondritis. That's a lot. From the patient's point of view, although they've been tested, a gamut of tests and specialists saying it's not your heart, every time the patient gets a strain or a pain coming in, especially when the doctor has said that it's going to settle down and it hasn't, then it's massively scary for the patient. If the doctor was wrong about it settling down, then maybe they were wrong about it not being the heart as well. So from the patient's point of view, it's not just the pain and disability, which can be quite major, but it's also seriously scary. And you do see anxiety, depression, overuse of doctors coming along in patients with this. Now, I got onto this almost by accident. In New Zealand, as a manual physiotherapist, that's a physio mostly using hands-on techniques, including manipulation, to treat various things, and in my case, mostly the spine over the last 30 years. My thumbs have finally mostly given out, and I have been lecturing at various medical conferences to doctors on spines, and I've also been adding in costochondritis. What happened was I was part of a panel a couple of years ago in a medical conference in New Zealand, which had a number of cardiologists and cardiac surgeons. We were talking about chest pain, and I was there to give a 15-minute riff on non-cardiac causes of chest pain. So I gave my New Zealand explanation that we don't find it difficult. It's basically the rib hinges around the back are frozen, therefore the ones on the front are straining, clicking, getting painful. It's almost like spraining your ankle. And that we actually don't find it difficult to treat, which we don't. From a manual physio point of view in New Zealand, this is easier than the average low back or neck problem. There are no discs involved generally, and it's just a matter of freeing up the tight machinery. The straining around the front is happening because of the hypomobility around the back on the ribs. So free that up, which is the object of treatment, and the strain around the front settles down. At the end of this panel, I got basically jumped on by the three guys nearest me who explained that they are swamped with this stuff. They are getting maybe up to half of their patients are not cardiac, but are essentially costochondritis, and it's getting between them and doing what they're trained to do, which is saving lives. So I sort of got frog-marched along to the British Medical Journal Australian people who were there, and they said, can we do an article for the BMJ reassessing costochondritis? So this is the research that we've done, and this is a quick first hit at the research. So there is a real need for a clear medical understanding of costochondritis. I had assumed that the rest of the world outside New Zealand and Australia, who also have very good manual physiotherapy skills, saw it the same way as we did, as a not particularly difficult mechanical problem to sort out. It turns out this is not the case. UK and US, it's seen as this mysterious inflammation, and a whole gamut of treatment then takes place, ramping up through various anti-inflammatories, various painkillers, steroid shots into the joints if they don't work, a whole ladder of specialists, including rheumatologists, and there is no indication whatsoever that it's a rheumatology condition. I'll come to that. And basically treatment that doesn't work. The settling down fast in a few weeks is largely reassurance to the patient. If you've frozen up the hinges around the back there, and that can happen for a variety of reasons, they can just stay tight. And very frequently that's what happens. It is hard to get a really clear handle on numbers, but it is probably quite large. Certainly anecdotally through the costochondritis groups, through contacts, through some of the popular stuff we've put out on YouTube about it, the costochondritis, which has just remained for months or more likely years and decades, seems to be very common. And it makes perfect sense if you look at it as essentially a joint problem rather than a mysterious inflammation. On patient.info, which is a popular UK-based medical site, on the Costochondritis Forum, I did an impromptu survey of the first 100 people who mentioned how long they'd had their costochondritis for. The average was 2.2 years, and of course they still had it. And this ranged from about 3 days through to about 35 years. Now, of course this is a biased sample, and of course it's not statistically accurate, but you get this all the way through. So it's a big problem, it's a big load on emergency room. It is painful and debilitating and very restricting when it's acute itself, and it is immensely scary for the patients. So, what's the existing research show? Well, Disler et al. In 1994, and I'll put all the exact references down underneath this YouTube video. So Disler looked at 122 acute chest pain patients who presented to an ER and gave 36 of them a costochondritis diagnosis. All of the research on costo is a bit fuzzy because nobody's quite sure what it is if they're seeing it in inflammatory terms. However, there was no significant difference at all between the 36 patients who were diagnosed by Disler and al. With costochondritis. No difference in ESR inflammatory blood levels between them and a control group who didn't have costochondritis but did have some degree of chest pain. So that's reasonably conclusive. There is no indication that costochondritis is a mysterious systemic inflammation manifesting itself at the sternocostal joints on the breastbone. And let's step back a second. There are various suggestions for causes for costochondritis, but any systemic cause, and I'll come to some of them shortly that have been mentioned, but like a systemic inflammation, why on earth would it manifest just at the sternocostal joints on the breastbone and nowhere else in the body? Now, other things have been mentioned. There are a few case studies, not many, about 2 cases from O and Johnson in 2012 where vitamin D levels were low in the costochondritis patients. They were given vitamin D, levels came back to normal, and the costochondritis wasn't there. This was in Hawaii. It's a case study of 2 patients only, and who knows what else they had after shifting to Hawaii. However, something like 34% of humans in Western society have low vitamin D anyway. So their conclusion was that low vitamin D could be a cause of costochondritis. That conclusion is really not warranted from the 2 case study patients that they had. I'll come back to that. Infection is another reason for costochondritis that's been mentioned, but again, the numbers are tiny. There are 2 case studies where E. coli after blunt trauma impact, and another case after surgery, created inflammation, infection at the costosternal joints. These are tiny numbers. The other thing that's been suggested was Candida albicans from Heckenkamp, 1997, makes the point how rare this is. All of this was either from blunt trauma or after surgery or needle shearing from drug addicts. So we're not looking at any sort of explanation from these which could account for the large numbers of costochondritis turning up to emergency rooms or A&E departments. One other thing that's been mentioned is chest binding, where you're doing a transition from female to male. They essentially wrap the torso up in corsets, and this can trigger costochondritis. Okay, so what we've got are suggestions for costochondritis. What is also in the research, but hasn't been picked up in the popular medical understanding of costochondritis, is the mechanical basis for it, which is how we would see it in New Zealand, how I personally see it, how the research supports it. Because there are a number of case studies that show that you fixed costochondritis by freeing up hypomobile, tight joints around the back, thoracic spine, and rib. There are several case studies from Gridgebers, Grindstaff, Martin Raby, writing in Manual Therapy in 2006, treated 2 cases of chronic costochondritis and fixed them both just by freeing up the hinges. The best piece of research relevant to costochondritis came through only in 2017, and is a case study of case series of 8 patients who had chronic costochondritis. Average time that they'd had it for was 6 months, who were all cured and demonstratedly stayed clear by Zaruba and Wilson, writing in the International Journal of Sports Physiotherapy from the University of Jamestown, Fargo in North Dakota. This is the best single piece of treatment evidence for costochondritis, and it is a case series of 8, and that's not very much, but it's the best there is. It does fit in completely with the New Zealand manual physiotherapy experience, and we think it's basically the case of basically the way you treat almost all costochondritis. So I'd like to mention, I'll come back to that again. I'd like to mention briefly that there is also a thing called Precordial catch syndrome, which is where you get just a flick of pain. We think it's essentially the same thing, but only very temporarily, where, say, one of the rib hinges around the back is tight enough to have stuck momentarily. You get that flick of pain across the chest, and all other tests are negative, and it's probably the same thing, although this is hypothesis, but it makes complete sense. So what we've got is a situation where you've got a medical view of costochondritis, which is convenient and easy to administer, in that you can give the patient medications, anti-inflammatory medications, steroid shots into the hinges, ramp up through various specialists. But it really does not seem a fit with the actual clinical event of this mysterious pain on the breastbone. The best model fit is the one I've been describing, where the basis is hypomobility, which can happen for a variety of reasons, of the ribs around the back, creating hypermobility, strain, pain, local irritation, local inflammation. The localized inflammation is really just inflammatory response. Same as a blister in your boot or going over on a sprained ankle. The swelling, we think, is just simply like the swelling you'll get with a sprained ankle. The joints are being strained. They'll frequently get a sharp stabbing pain if the rib hinge gives sufficiently, a bit like spraining your ankle. A sharp stabbing pain is not an inflammatory symptom. Inflammation is silent and constant. There are other indications clinically as well. clicking and popping of the sternocostal joints. This is a bit like cracking your knuckles. It's the joints giving a bit. Again, it's a mechanical symptom. It's not an inflammatory symptom. Frequently with costochondritis, there is a breathlessness. And again, heart and lungs check out fine. The explanation is that if the rib hinges are tight around the back, then you simply cannot fill your lungs fully because you can't expand your rib cage fully. This seems to be the basis for the number of clear lung investigations that come through with costochondritis, but the patients are still saying they're breathless. Also, of course, X-ray, CAT scan, MRI are still photos and will not show whether the rib hinges around the back or the thoracic facets can move or not. So they can be frozen solid and still causing the problem, although you get a clean bill of health on the scans. I would like to say that I think this is quite common, that everybody concentrates on the lungs but misses the actual ribcage expansion. There is a very simple clinical test that we use in New Zealand manual physio. You sit the patient down on the plinth and see what sort of thoracic rotation in both directions they've got. Just take hold of their shoulders and see how far they'll come. It should be around about 90 degrees in both directions, with the shoulders coming in line of the thigh. It's a very simple test to do. Now, I've had correspondence with patients where they've had costochondritis for 5 years, got them to do this test by email because they were in the United States, and they could go around almost 90 degrees away from the side of the pain on their breastbone, but only 45 degrees, and it brought the pain on acutely back towards the costochondritis side. And the explanation is that it's tight, frozen rib hinges around the back, 5 years worth, and they are only allowing the thoracic spine to go that far around before it hurts. The breastbone hinges freeze and strain rather, and the pain comes on. Now, the point about this was that I got the patient to do this at home, and this was the first time that anybody of all the doctors and specialists she had seen for her costochondritis had ever, at the first time it had ever happened. So I do think it's getting missed. Basically, the word costochondritis implies that it's an inflammatory condition, best treated, therefore, medically by medications, steroids, what have you, to suppress this mysterious inflammation. I think it's actually a field problem. It should be a physiotherapy, physical therapy, manual therapist problem, essentially, and treated as such, and it's not. If you do treat it like that, we find it quite simple. We actually use a spinal fulcrum called the Backpod in New Zealand, which is something the patient can lie back on, and it provides a strong, localized, sustained stretch to the tightened collagen around the rib hinges, which is very, very effective in quietly freeing them up. And the way you fix costochondritis, in our opinion, and supported by the best of the available research, is by freeing up the tight rib hinges around the back causing it. This means that every treatment directed solely at the scary pain on the front is missing the point. And I must say, with all the research that I've gone through, I have not seen anywhere any question of exactly why is the pain there in the first place. So that's the overview. That's what we found going and having a look. We're still doing the BMJ article. It hasn't been completed yet. But there seems to be this disconnect between the manual therapy model, especially from Australasia, in terms of fixing costochondritis, and the way it's treated elsewhere through the medical system, and is a burden on the medical system which I think is unnecessary. Lastly, I would say that physical therapists in America will often treat it as they would treat a lot of mechanical problems with strengthening, stretching, and exercise approach. In practical terms, this doesn't work with costochondritis because if the rib hinges are jammed around the back, any stretch or exercise you get the patient doing will only strain the already strained rib hinges on the sternum further, way before you get a benefit through to the hypomobile tight rib hinges around the back. So just going in with the usual exercise prescription physical therapy or physiotherapy approach does not tend to fix costochondritis. It flares it up. It's not like a muscle strain. So we find that you have to unlock, free up and unlock the hypomobile ribs around the back first. I hope that makes sense. There are a lot of people out there unnecessarily putting up with pain. We certainly commonly get approached by people who've had it for things like 25 years, 35 years, and we've still had them respond. Pain clinics, pain specialists take the model that they have to modify the pain impulses once we're there. In the case of costochondritis, almost always what they're missing is standing back and seeing that there is an ongoing mechanical problem there which is driving the pain, and that therefore just trying to put the lid on it once it's produced is not going to have very good results. So we think there's a very simple mechanical basis to almost all costochondritis, and that mechanical basis means it's a reasonably fixable, really readily fixable mechanical physio problem. That's our overview, and I hope you find it useful. My name's Steve August. I'm welcome to be contacted on this. My email is bodystance@gmail.com. You can find more information about it on the Backpod's website, www.backpod.co.nz. It's Backpod, backpod.co.nz. It's an area that we've been sucked into, and we think we're being useful in it. Good luck.